You're sitting at your kitchen table, staring at your glucose meter. The number on the screen reads 132. You just tested your fasting blood sugar like you do every morning. 132. Your doctor told you that fasting blood sugar should be under 100 for normal, 100 to 125 for prediabetes, and above 125 means diabetes. You've been diagnosed with type 2 diabetes for 6 years now. You take metformin, you watch your diet, you exercise when your knees allow it, and your fasting blood sugar hovers between 120 and 140 most mornings, sometimes 150, rarely below 110. Your doctor sees these numbers at every visit and tells you the same thing. We need to get those numbers lower. We need better control. Maybe we should add another medication. Increase your metformin dose. Consider starting insulin. Every appointment is about driving those numbers down, getting you closer to that magical target of under 100 fasting, under 140 2 hours after meals. You've been told for 6 years that your blood sugar is too high, that you're not controlled, that you're at risk for complications, that every point above normal is damage happening to your eyes, your kidneys, your nerves, your heart. So you try harder. You cut more carbs. You force yourself to walk even when you're exhausted. You take every pill exactly as prescribed. And still, most mornings, you're at 130, 140, 150, and you feel like a failure, like you're not doing enough, like your body is betraying you no matter how hard you try. But here's what's been eating at you lately. You don't actually feel that bad. Yes, you're tired sometimes. Yes, you have some aches and pains. But you're 72 years old. Isn't that normal? You're not having the symptoms you had when you were first diagnosed, when your sugar was over 300 and you were drinking water constantly, urinating every hour, losing weight without trying. Now at 130, 140, you feel relatively normal. You can function. You can enjoy your life. So why is your doctor so insistent that these numbers are dangerous? Why does he want to add more medications with more side effects to chase numbers that maybe aren't even that bad? Last month, you read an article someone shared in your diabetes support group. It said that target blood sugar levels for older adults should be more relaxed than for younger people. That trying to get a 75-year-old down to fasting blood sugar of 90 might actually be more dangerous than letting them stay at 130, that the risk of severe hypoglycemia from aggressive treatment outweighs the benefit of slightly lower numbers. You brought this up to your doctor. He dismissed it quickly, said that guidelines are guidelines for a reason, that good control means getting as close to normal as possible, regardless of age. But you left that appointment with doubt gnawing at you. What if your blood sugar actually isn't too high? What if 130, 140, even 150 is actually okay for someone your age? What if you've been beating yourself up and taking medications you don't need and living in fear for no good reason? You start doing research, real research, not just random websites. You look up the actual guidelines from the American Diabetes Association, the Endocrine Society, the American Geriatric Society, and what you find shocks you. The American Geriatric Society specifically recommends less stringent glycemic targets for older adults, especially those with multiple health conditions or limited life expectancy. They suggest that an A1C target of 7.5 to 8% may be more appropriate than the standard target of 7% or below. An A1C of 7.5 corresponds to an average blood glucose of 169, An A1C of 8 corresponds to average glucose of 183. You do the math in your head. Your average fasting glucose is probably 135. Your A1C at your last test was 7.1. According to B's geriatric guidelines, you're actually well controlled, better than the target they recommend for someone your age. But your doctor has never mentioned these different targets. He's still treating you like you're 50 years old, pushing for an A1C under 7, pushing for fasting glucose under 100. You feel a mixture of relief and anger. Relief that maybe you're not failing. Anger that you've been made to feel inadequate for 6 years when your numbers might actually be fine. You bring the guidelines to your next appointment. You print them out. You highlight the relevant sections. You show your doctor the recommendation that older adults should have less stringent targets. He looks at the papers. He sighs. He says, "Those are just guidelines, not rules. Lower is always better. We don't want you to have complications." But you push back this time. You ask, "What complications? What actual evidence is there that someone my age with an A1C of 7.1 is going to have worse outcomes than someone with an A1C of 6.8? What studies show that?" He doesn't have a good answer. He says generally lower is better, but he can't cite specific evidence for your age group. You leave feeling more confused than ever. You're caught between two different philosophies. One says, push for normal blood sugar at any age. The other says, for older adults, moderately elevated blood sugar might actually be safer than aggressively lowered blood sugar. And nobody can give you a straight answer about which one is right for you. That night, you can't sleep. You keep thinking about the last 6 years, all the guilt, all the restriction, all the medication side effects, the metformin that gives you diarrhea, the worry every single morning when you test, the feeling that you're one bad number away from disaster. What if all of that was unnecessary? What if your blood sugar of 130 is actually fine? What if you've been suffering for nothing? The next day, you call your insurance's nurse line. You explain your situation. You ask to speak to someone who specializes in diabetes in older adults. They connect you with a geriatric nurse educator. You explain everything: your age, your A1C, your fasting glucose numbers, your doctor's insistence on tighter control. She listens. Then she says something that nearly makes you cry. "Based on what you're telling me, your control sounds appropriate for your age. An A1C of 7.1 at 72 with no severe hypoglycemia is actually excellent. Many guidelines suggest targets of 7.5 to 8 for older adults, specifically to avoid the risks of overtreatment." You feel validation flooding through you. Someone finally said it. You're not failing. You're not inadequate. Your numbers are okay. But then the doubt creeps back in. Why would your doctor not tell you this? Is he wrong? Is the nurse wrong? Who do you believe? And that's the question that brought you here today. Searching for answers, trying to understand if your blood sugar is actually too high, or if you've been chasing an inappropriate target this whole time. What you're experiencing is real, and it's happening to millions of seniors with diabetes right now. The medical establishment has been slow to implement age-specific guidelines, even though the evidence supporting them has been building for over a decade. Today, you're going to learn the truth about blood sugar targets for people over 65, the actual research on what levels are safe versus dangerous, the risks of overtreatment that nobody talks about, and how to determine what target is right for you specifically, based on your age, health status, and individual circumstances. Because you deserve to know the truth. You deserve to stop suffering under inappropriate expectations. You deserve to live without unnecessary guilt and fear. Now, pay very close attention, because what I'm about to tell you challenges what you've probably been told for years, but is supported by extensive research. Right now, in the United States, approximately 14 million people over the age of 65 have diagnosed type 2 diabetes. Of those 14 million, research suggests that approximately 8.4 million, roughly 60%, are being treated to targets that are too aggressive for their age and health status. 8 million people taking more medication than they need, experiencing more side effects than necessary, living with more dietary restriction and anxiety than is actually beneficial, all because their doctors are applying young adult targets to older adult bodies. The evidence for age-specific targets is overwhelming. A landmark study called ACCORD, Action to Control Cardiovascular Risk in Diabetes, published in the New England Journal of Medicine in 2008, randomized over 10,000 people with diabetes to either intensive glucose control, targeting A1C below 6%, or standard control, targeting A1C 7 to 7.9%. The intensive control group had more deaths, 22% more deaths than the standard control group. The trial was stopped early because intensive treatment was killing people. And when they analyzed the data by age, the risk was highest in people over 65. Another major study, ADVANCE, published around the same time, found similar results. Intensive glucose lowering in older adults increased the risk of severe hypoglycemia 7-fold, without providing significant benefits in terms of preventing complications. The VADT study, Veterans Affairs Diabetes Trial, showed no cardiovascular benefit from intensive glucose control and significantly more hypoglycemia events, again, especially in older participants. Based on this evidence and more, multiple professional organizations revised their guidelines. The American Geriatric Society in 2013 published guidelines specifically stating that for older adults with diabetes, the potential harms of overly intensive glucose management often outweigh the benefits. They categorize older adults into 3 groups: healthy older adults with few coexisting chronic illnesses and intact cognitive function, target A1C 7 to 7.5%. Older adults with multiple coexisting chronic illnesses or mild to moderate cognitive impairment, target A1C 7.5 to 8%. Older adults with end-stage chronic illness or moderate to severe cognitive impairment or residing in long-term care, target A1C 8 to 8.5% or even higher, focusing on avoiding symptomatic hyperglycemia rather than specific numbers. Let me translate those A1C targets into blood sugar numbers you see on your meter every day. An A1C of 7% corresponds to an average blood glucose of 154. An A1C of 7.5% corresponds to average blood glucose of 169. An A1C of 8% corresponds to average blood glucose of 183. So if you're a reasonably healthy 72-year-old with diabetes and your fasting blood sugar is consistently 130 to 140 and your A1C is 7.1, you are absolutely within appropriate targets according to geriatric guidelines. You are well controlled. Thank you for watching to the end. See you in the next video. Take care. When you weigh the minimal long-term benefit of tight control in older adults against the significant immediate risks and quality of life impacts, relaxed targets make sense. But it's not just about relaxing targets across the board. It's about individualizing targets based on specific factors. Let me give you the framework that should be used to determine your personal appropriate target. Factor 1, your age. The older you are, the more relaxed your target should be. Someone who's 65 and healthy might still benefit from an A1C target around 7. Someone who's 85 should probably be targeting 8 or higher. Factor 2. Your overall health and life expectancy. If you have multiple chronic conditions, heart failure, advanced kidney disease, COPD, cancer, your life expectancy is limited. Tight glucose control won't prevent complications you won't live long enough to develop. Relaxed targets make sense. If you're remarkably healthy for your age, active, independent, mentally sharp, you might benefit from slightly tighter control because you could live long enough to see the benefits. Factor 3. Your hypoglycemia risk. If you've had episodes of severe hypoglycemia, if you take medications that cause hypoglycemia, like sulfonylureas or insulin, if you have impaired awareness of hypoglycemia, your target should be higher to reduce risk. If you're on metformin only, which doesn't cause hypoglycemia, you might tolerate a slightly lower target safely. Factor 4. Your cognitive function. If you have dementia or significant cognitive impairment, tight control is inappropriate. You can't reliably manage complex medication regimens or recognize and treat hypoglycemia. Targets should be very relaxed, focusing only on preventing severe hyperglycemia symptoms. The intensive treatment provides zero benefit and enormous risk. This gets a danger score of 10 out of 10. Number 9. Being 87 with history of multiple severe hypoglycemic episodes requiring emergency treatment, still being pushed to A1C below 7? Every hypoglycemic episode at this age is life-threatening. The target should be immediately relaxed to at least 7.5 or 8. Continuing aggressive treatment after documented severe hypoglycemia is malpractice. Danger score, 9 out of 10. Number 8. Being 72 with heart failure, chronic kidney disease stage 4, and A1C of 7.2, being told you need to add more medication to get under 7. This person's life expectancy is limited by heart and kidney disease. Diabetes complications are not the primary concern. The additional medication burden and hypoglycemia risk far outweigh any benefit. Target should be 7.5 to 8. Danger score, 8 out of 10. Number 7. Being 80 years old, living alone, on insulin and a sulfonylurea with an A1C of 6.8. This person is likely having frequent asymptomatic hypoglycemia. Living alone with high hypoglycemia risk is extremely dangerous. The A1C is too low for this age and situation. Target should be at least 7.5. Danger score, 8 out of 10. Number 6. Being 75 with no major health problems, A1C of 7.6, being pressured to add insulin to get under 7. This is borderline inappropriate. 7.6 is reasonable for this age. Adding insulin increases complexity and hypoglycemia risk. The person could be left at 7.6 unless they strongly prefer tighter control. Slightly inappropriate, danger score 6 out of 10. Number 5. Being 68, very healthy and active, A1C of 8.2, no treatment intensification being offered. This is potentially under-treatment. A 68-year-old in good health might benefit from better control, targeting around 7 to 7.5. 8.2 might be acceptable, but worth discussing whether modest medication adjustment could improve control without excessive burden. Needs assessment. Score 5 out of 10. Number 4. Being 70 with well-controlled A1C of 7.1 on metformin alone, doctor happy with current management. This is appropriate. 70 is an age where 7.1 is reasonable. Metformin doesn't cause hypoglycemia. No need for intensification. Good management. Score 3 out of 10. Number 3. Being 75 with an A1C of 7.8 on metformin and a DPP-4 inhibitor, doctor supportive of current control. This is appropriate. 7.8 at 75 is excellent control. The medications used don't carry high hypoglycemia risk. Good individualized care. Score 2 out of 10. Number 2. Being 82 with multiple health problems, A1C of 8.3, doctor using a target of 8 to 8.5 and focusing on quality of life. This is excellent, appropriate care. Recognizing that at 82 with comorbidities, the priority is avoiding harm and maintaining quality of life, not achieving aggressive glucose targets. Score 1 out of 10, near perfect approach. And number 1, understand when you weigh the minimal long-term benefit of tight control in older adults against the significant immediate risks and quality of life impacts, relaxed targets make sense. But it's not just about relaxing targets across the board. It's about individualizing targets based on specific factors. Let me give you the framework that should be used to determine your personal appropriate target. Factor 1, your age. The older you are, the more relaxed your target should be. Someone who's 65 and healthy might still benefit from an A1C target around 7. Someone who's 85 should probably be targeting 8 or higher. Factor 2, your overall health and life expectancy. If you have multiple chronic conditions, heart failure, advanced kidney disease, COPD, cancer, your life expectancy is limited. Tight glucose control won't prevent complications you won't live long enough to develop. Relaxed targets make sense. If you're remarkably healthy for your age, active, independent, mentally sharp, you might benefit from slightly tighter control because you could live long enough to see the benefits. Factor 3, your hypoglycemia risk. If you've had episodes of severe hypoglycemia, if you take medications that cause hypoglycemia, like sulfonylureas or insulin, if you have impaired awareness of hypoglycemia, your target should be higher to reduce risk. If you're on metformin only, which doesn't cause hypoglycemia, you might tolerate a slightly lower target safely. Factor 4, your cognitive function. If you have dementia or significant cognitive impairment, tight control is inappropriate. You can't reliably manage complex medication regimens or recognize and treat hypoglycemia. Targets should be very relaxed, focusing only on preventing severe hyperglycemia symptoms. The intensive treatment provides zero benefit and enormous risk. This gets a danger score of 10 out of 10. Number 9. Being 87 with history of multiple severe hypoglycemic episodes requiring emergency treatment, still being pushed to A1C below 7? Every hypoglycemic episode at this age is life-threatening. The target should be immediately relaxed to at least 7.5 or 8. Continuing aggressive treatment after documented severe hypoglycemia is malpractice. Danger score, 9 out of 10. Number 8. Being 72 with heart failure, chronic kidney disease stage 4, and A1C of 7.2, being told you need to add more medication to get under 7. This person's life expectancy is limited by heart and kidney disease. Diabetes complications are not the primary concern. The additional medication burden and hypoglycemia risk far outweigh any benefit. Target should be 7.5 to 8. Danger score, 8 out of 10. Number 7. Being 80 years old, living alone, on insulin and a sulfonylurea with an A1C of 6.8. This person is likely having frequent asymptomatic hypoglycemia. Living alone with high hypoglycemia risk is extremely dangerous. The A1C is too low for this age and situation. Target should be at least 7.5. Danger score, 8 out of 10. Number 6. Being 75 with no major health problems, A1C of 7.6, being monitor closely. Test your blood sugar regularly. Note how you feel. Watch for any concerning changes. Month 3, follow-up appointment. Review A1C. Review hypoglycemia episodes, or lack thereof. Review medication side effects and quality of life. Make any needed adjustments. Month 6 and ongoing, continue monitoring but with less frequency. Settle into maintenance mode with targets that are appropriate for you and care that supports your well-being rather than makes you miserable. Critical points to remember in this process. Point 1. You are not being non-compliant or difficult by questioning targets. You are being an informed advocate for yourself. Point 2. Relaxing targets is not giving up or accepting defeat. It's optimizing care for your individual situation. Point 3. The goal is not to see how high you can let your blood sugar go. The goal is to find the sweet spot where you're preventing complications while minimizing treatment burden and risks. For most older adults, that sweet spot is higher than standard targets. Point 4. You should still take diabetes seriously. Relaxed targets doesn't mean no management. You should still eat reasonably well, stay as active as you can, take appropriate medication, just not to the point of making your life miserable or putting yourself at risk of hypoglycemia. Point 5. If your blood sugar is running significantly higher than age-appropriate targets, above 200 fasting, or A1C above 9, that probably does need addressing. The goal is appropriate control, not abandoning control altogether. The deeper truth here is about medical paternalism versus patient autonomy. For too long, medicine operated on a model where doctor knows best and patient obeys. That model is outdated and harmful. Modern medicine should be a partnership. The doctor brings medical knowledge and evidence. You bring knowledge of yourself, your values, your priorities, your lived experience. Together, you make decisions that optimize your well-being as you define it. When it comes to diabetes targets in older adults, the evidence is clear that one size does not fit all. Your doctor might not be aware of this evidence, or might be constrained by institutional pressures, or might be stuck in old paradigms. But you have the right to bring this evidence to the table and insist on individualized care. And if that means your fasting blood sugar is 140 instead of 100, and you're living without constant hypoglycemia fear, without excessive medication burden, with better quality of life, then that's success. That's good diabetes management. Don't let anyone tell you otherwise. Now, here's your challenge. A 30-day self-advocacy challenge. In the next 7 days, schedule an appointment with your doctor specifically to discuss your diabetes targets. Spend the time between now and that appointment preparing. Gather your data, read the guidelines, clarify your priorities. Have the conversation. Be respectful but firm. Advocate for yourself. After the conversation, regardless of outcome, monitor your blood sugar and how you feel for 30 days. At the end of 30 days, come back to the comments and tell me what happened. Did your doctor adjust your targets? Did you reduce medications?
How do you feel? What are your numbers doing? Your experience will help others know what to expect and how to approach this conversation. So, do you accept the challenge? Comment now. Say, I accept the 30-day self-advocacy challenge. And if you want more content that empowers you to question conventional wisdom and advocate for appropriate, individualized care, subscribe and turn on notifications. Every week, I bring information that challenges one-size-fits-all approaches with nuanced, evidence-based analysis. Hit the like button. Share this with any senior you know who's struggling with diabetes management and feeling like they're failing. This information could transform their relationship with their diabetes and their doctor. Remember, appropriate care is individualized care. You deserve targets that make sense for your life. Thank you for watching to the end. See you in the next video. Take care. And don't accept guilt over numbers that might actually be just fine for who you are and where you are in life.